अच्छा 3 बजे से चलेगी, 3 बजे से चलने। म्यूट करते हैं, म्यूट करते हैं, म्यूट।
Audio control. Yes, hello, welcome, Dr. Sodh. Can you hear us?
Yes, sir. I can, sir.
Good afternoon, and welcome to our this SGPGI course 0102 course on telemedicine basics. And I welcome all the attendees. Till now, 41 have been connected, so we expect more to also connect. So yesterday we had 100 odd attendees, 113. Okay, right. So, Dr. Sodh, I think you'll appreciate this has needed the hour to let people know so many things are happening and happened, and what is going to happen in the future. And these are the kind of attendees who are going to really use this actually. They know about it. In that context, School of Telemedicine and SGPGI on behalf of National Institute of Health and Family Welfare, Government of India. So as a National Resource Center, we are launching this program. This will be repeated every 3 months. We'll repeat it. So with that introduction, I again thank you for accepting our request to be a faculty in this program. And Siddharth Mohali has contributed a lot in terms of telemedicine for over 20 years. And Dr. Sodh is already working there in the Department of Health Informatics in Siddharth Mohali. And he is in the position of your associate director, isn't it?
Yes, sir.
Associate director in Health Informatics division in Siddharth Mohali. And we have personal interaction with the Siddharth Mohali and other Siddharth. You'll find many Siddharths also part of this course, and especially in Siddharth Mohali in the field of telemedicine. So we started our collaboration way back in 2001 when they were part of our major project with the Government of India. Later on, Dr. Sodh moved to Mauritius, and he was in charge of our Government of India IT center there on behalf of Siddharth. Then he was also involved with a WHO consultant, also work in the Afro region. And he has been a continuously sought after experts in e-health by different international agencies. Coming to the core area of telemedicine and e-health, you don't have to see what they have done in the past. You might not have known also what has been done by them, but what is more important to know you is eSanjeevani, which all of you know, right? And to make the eSanjeevani, they have worked very hard for last 20 years. So what you see eSanjeevani now is recycled products of so many rounds of cycling has been done to reach at this eSanjeevani stage. So now it is very popular, and this is recognized as a national telehealth telemedicine software, and the government has recognized these things, and all the state governments are utilizing this under the National Health Mission. So you'll be speaking about all those things. So without spending much of time, you'll find out their work from their presentation actually. Dr. Sodh, please go ahead, and you have 20 minutes. After that, we'll have a presentation closer, then we'll have interactions.
Fine, sir. Thank you. Thank you very much, sir, for your kind words and detailed description about Siddharth Mohali's role in telemedicine and the way we got on board this telemedicine bandwagon way back in 2001 and launched the first version of Sanjeevani that was that linked SGPGI Lucknow with AIIMS New Delhi and PGI MER Chandigarh. So I'll share my presentation, and we'll then
please go ahead.
Further. I hope my screen is visible.
Yes,
sir?
visible. It's visible, or your audio is very clear. Please go ahead.
Fine. So eSanjeevani, that is now modeled into the National Telemedicine Service of Government of India. We've already served over 1.4 crore patients through this platform, which basically is now available in two variants. On the left side, we have doctor-to-doctor variant, which is called eSanjeevani and is functional under Ayushman Bharat at health and wellness centers. On the other side, we have patient-to-doctor variant, which is called eSanjeevani OPD, and is meant for seeking health services through telemedicine or remotely by the populace in the country. And this is available in over 30 states in the country. Since the implementation or since the launch of eSanjeevani, eSanjeevani OPD was launched to tackle the challenges those were thrown at us or thrown at the Indian healthcare delivery system while the COVID struck Indian shores. All the OPDs were closed, and the Government of India wanted to provide health services to the patients on non-COVID, I would say, aspects to the patients in the confines of their homes. and hence eSanjeevani OPD was developed in a very rapid mode, and it was rolled out within a span of around 19 days from the day we started working on it in its minimalistic form. And since then, eSanjeevani has evolved rapidly, and it has been adopted by over 30 states. And we have more than 23,000 doctors who've been trained, and they practice on eSanjeevani OPD on almost as per the rosters, those are finalized by the state governments. And so far, over 50 lakh citizens have sought services over eSanjeevani OPD. On the other side, that is eSanjeevani ABHWC, that is Ayushman Bharat Health and Wellness Centers. We have this doctor-to-doctor variant operational in 26 states, and there are more than 30,000 doctors and even paramedics who are using eSanjeevani. And we've done over 86 lakh consultations on eSanjeevani Health and Wellness Centers model. As far as the trend or the adoption of eSanjeevani is concerned, eSanjeevani Health and Wellness Centers was rolled out in November 2019. Although this has been a part of the Health Ministry's forward-looking agenda, or the forward-looking stance that they had envisioned, or rather conceptualized, conceptualized the operationalization or enablement of health and wellness centers with telemedicine way back in 2019, or rather 2018. They started planning telemedicine for all the health and wellness centers. And it was in 2019 November that we had rolled out eSanjeevani in Andhra Pradesh Health and Wellness Centers under Ayushman Bharat scheme. So initially, it was doing around 3,000 consultations a month. And gradually, it was in the month of April, as I said, that eSanjeevani OPD was launched. And since then, there's been a very quick, or rather an exponential growth in the adoption of telemedicine. And we can say from around 3,000 consultations a month in November 2019, we could achieve over 2 million consultations a month, and that is 21 lakhs and 10,138 consultations we logged in the month of September. So that has been the exponential rise of eSanjeevani or telemedicine in the country. And as a result, this is the breakup of the consultation as on date. We've done around 14.6 million consultations, out of which more than 90 lakh consultations are in eSanjeevani HWC and over 55 lakh consultations in eSanjeevani OPD. The states in the southern part of the country are more, I would say, are active in using eSanjeevani, and there are certain North Indian states as well, like Uttar Pradesh is the leader in the north. Gujarat is doing very well on the western side, and West Bengal is also gaining rapidly. And states like Bihar, they've really surprised the entire, I would say, telemedicine fraternity with the way that they have adopted telemedicine, and they have scaled this all in no time. I'll first talk about eSanjeevani OPD and then move on to eSanjeevani Ayushman Bharat and Wellness Centers. As far as eSanjeevani OPD is concerned, as I said, it was rolled out during the pandemic, and all the OPDs were closed in those days. And we had designed eSanjeevani OPD based on the directions or the guiding philosophies from the Ministry of Health and Family Welfare, that this being the first of its kind of a public-facing telemedicine application by the government in India. Hence, it had to be a very user-friendly, citizen-friendly application, and then it had to be secure, and it had to be scalable as well, because it was expected that lots and lots of people would use it. So the entire process of using eSanjeevani or consulting a doctor was almost put together in 5 processes or 5 steps. And this was designed in such a way that it would mimic the traditional OPDs in the hospitals. So the patient would verify the cell number through OTP, then generate a token for a specific OPD, and then log in as soon as he or she gets the notification to see the doctor, closer to the turn and his or her turn. And then after the patient logs in, gets into the queue, say in less than 7 or 8 minutes, in less than 8 minutes, the patient would have his turn and would speak with the doctor through a video consultation, and the doctor would write down the e-prescription, and at the end of the consultation, the prescription would be flashed on the screen, as well as a SMS would go with a link to the patient. So gradually we scaled up eSanjeevani, and it evolved into I would say it is now the country's biggest OPD, and we are running over 450 OPDs, and out of those 400 OPDs are specialty and super specialty OPDs. And daily over 3,000 of those 26,000 doctors practice telemedicine using eSanjeevani. And we have premier institutions like AIMS and various other medical colleges and specialized hospitals who have their OPDs available on eSanjeevani. And in certain states, ASHA workers and community health officers are also facilitating eSanjeevani OPD consultations. And during the second wave of COVID, the Ministry of Defense was kind enough to put together a group of doctors, all ex-AFMS doctors, who had set up a national OPD on eSanjeevani OPD, and patients from all over the country could access or could avail the services of these doctors using eSanjeevani. And as on date, we have almost around 2 million downloads of Android application, and that makes it one of the most popular e-governance or government-owned applications, mobile applications. We very recently launched iOS version of the app as well, and that is also gaining popularity. Based on the potential or the benefits that telemedicine has, various states had designed very innovative modalities to use eSanjeevani OPD, like the state of Jharkhand. In initial days when the vaccination had just started and it was meant only for the selected section of the populace, they had put together a mechanism, and we had set up an OPD on eSanjeevani OPD, wherein the patients or the citizens were not required to go to a health facility to get the comorbidities certificate, and because that was mandatory for just about everyone who's wanting to get vaccinated, that the certificate must be with the individual before for getting a vaccination. And state of Jharkhand had put together this process, and we had enabled that on eSanjeevani OPD. And then state of Kerala had rolled out numerous district early intervention centers, which is a part of the Rashtriya Swasthya Bal Karyakram. And these district early intervention centers enabled the parents and the children to connect with the doctors and specialists to discuss cases pertaining to the children's growth. And there were numerous COVID-19 OPDs on eSanjeevani OPD, and certain states had mandated to COVID positive patients who were home quarantined to at least to seek one consultation per day over eSanjeevani OPD, and that was mandated by them. And then a few other states had rolled out COVID-19 OPDs to screen patients, and state of Gujarat utilized final year medicos or medical students to run these OPDs as per the regulations put together by the Ministry of Health and Family Welfare. Then there have been numerous instances where the doctors practicing on eSanjeevani OPD have been able to identify cases which were otherwise life-threatening, and enable these patients to connect with the local authorities, or rather connected the local authorities with the patients, got them transported to the nearest district hospital, and even got them admitted. In certain cases, patients with strokes, etc., were sort of admitted in ICUs, etc. And then in few states like Tamil Nadu and Kerala, they had also set up HIV/AIDS OPDs specifically for people living with HIV. And in Kerala, again, they had another innovative application of eSanjeevani, wherein it was set up in the jail, Palakkad district jail, and the inmates of that jail could access or could avail, could consult doctors using eSanjeevani OPD, and hence without having to been taken to the hospitals for consultations. Hence, they basically set up a case or a best practice, wherein all other states also started planning eSanjeevani OPD for inmates in orphanages, in old age homes, and even jails. And this is the sample e-prescription that gets generated out of eSanjeevani OPD after the consultation. And the doctors in the left image top, we can see the doctors practicing telemedicine using eSanjeevani OPD. And there are regular training sessions, those are conducted, although this picture was conducted in pre-COVID times when eSanjeevani HWC was rolled out. And the right picture shows elderly couple seeking services of doctors through eSanjeevani OPD. And there have been numerous such cases where the populace otherwise would not have been able to access specialized health services, but they could do so while sitting in rural areas, and they were able to speak with their specialists in hospitals like AIMS Rishikesh and AIMS Bilaspur, etc. And based on the analysis that we saw, this was a part of, I mean, the earlier version of this particular graph was a part of the Indian economy survey, which showed, which plotted a graph between the internet penetration in the state versus the number of eSanjeevani consultations per million population. It shows a very interesting fact that these states which are lower on with respect to internet penetration, like Uttarakhand, Karnataka, and Andhra Pradesh, they are doing pretty good, although they are below the national internet penetration average. So that reflects that people really have accepted modalities like telemedicine, etc., and they are wanting to utilize this in case they are available. So we have we can see states like Tamil Nadu, Karnataka, they are doing exceedingly well, because daily we see Andhra Pradesh doing around 50,000 consultations. Karnataka does more than 10,000 consultations, and this is how in eSanjeevani OPD on the 7th of October, we keep tracking the way the load of patients or the consultations goes up and low on eSanjeevani OPD. The blue graph shows the number of consultations those are happening at a given time, and the green graph shows the number of doctors those are actually present in the OPD serving the patients at that time. So we help the state governments or the state health departments or the NHM in the state to sort of optimize the utilization of the platform by roping in more doctors in a specific time, and so that they can increase they can increase the throughput and reduce the patient waiting time. As of now, the average patient waiting time on eSanjeevani is less than 8 minutes, which is a great, I would say, privilege to the populace that is using eSanjeevani OPD. And we have eSanjeevani OPD, which has already done more than 10 million 1 million consultations, 1 million downloads. And we also have eSanjeevani in the iOS format, and that is also doing very well. As far as eSanjeevani Ayushman Bharat Health and Wellness Centers is concerned, it has shaped into one of the cornerstones of the scheme for the objectives that it is addressing shortage of doctors and specialists at the ground level, and it is also reducing the burden on the secondary and tertiary level hospitals, besides boosting the digital health ecosystem in the country. The government of India had put together telemedicine guidelines for implementing telemedicine at health and wellness centers. In all, by end of December 2022, we are supposed to implement eSanjeevani at 155,000 health and wellness centers. So far, we've done the implementation, or we've enabled 30,000 health and wellness centers with telemedicine or eSanjeevani, and very soon we'll be crossing figure of 50,000, because daily we are doing close to around 200 or so health and wellness centers, and they are getting on board the national telemedicine network. As far as doctor-to-doctor telemedicine consultations are concerned, it is a three-tiered model. In fact, this is or rather, this is a unique telemedicine platform which we put together as per the vision of Ministry of Health and Family Welfare. All across the world, we have not come across a model which is a two-tiered telemedicine model. A person at the top, the sub-center walks in, a patient walks in at the sub-center. Each sub-center is addressing a populace of around 5,000. So that means it is one sub-center takes care of one or two villages. And the patient, normally at the sub-center, there is no medical officer or no doctor available. The community health officer or a multi-purpose health worker normally service the patients, and they provide over-the-counter drugs which are a part of the essential drug list. And in case they are not able to address the problem of the patient who are walking in at sub-center, they then connect, they create the profile of the patient on eSanjeevani Health and Wellness Centers and link the patient with the hub, because this model is operational in the spoke and a hub format. So they connect the patient with the doctor available in the hub, and the hub could be at a PHC, it could be at a medical college, or it could be at a district hospital as well. So they connect the patient with the next hub. It could be a PHC. In case it is a PHC, a medical officer gets to see the patient. And in case the medical officer feels that the patient is supposed to be seen by a specialist, then the case is forwarded to the next level, next tier, that could be at a hospital or a medical college. And there the specialist goes through the case and sends the e-prescription or generates an e-referral, which then the patient uses to get admitted in case the admission is required at the nearest hospital or wherever the Ayushman scheme's beneficiaries can be serviced. And we have implemented it, as I said, at 30,000 health and wellness centers, and over close to around 3,000 hubs have been set up. And ASHA workers are also in Andhra Pradesh. We've tested a model wherein the medicines can also be delivered by the at homes by the ASHA workers. Once the prescription is generated, a copy of it goes to through the integration that we've done with NHM applications. The prescription goes to the pharmacist in the block, and the ASHA worker collects the packet of medicines and delivers it at the home, clicks a picture at the patient's home, and then uploads it to the server. And the coordinates also prove that the medicines have been dispensed or delivered. And this is the sample prescription that comes out of eSanjeevani Health and Wellness Centers. Based on the success of eSanjeevani, the Ministry of Defense came forward, and they wanted a telemedicine platform for the serving personnel and their dependents. So we put together services, e-health assistance and teleconsultation, which is sehatopd.in, sehatopd.gov.in. It also has an Android and an iOS application. So this is being used by the defense personnel and their defense personnel of tri-services, Indian Army, Air Force, and Navy, and their dependents. So this was rolled out in May this year. We had a basic version available to them last year as well. And we are also putting together for Ministry of External Affairs e-Arogya Bharati, an initiative which will connect all the African countries with Indian specialists, wherein the Indian specialists will provide their assistance or their guidance to the doctors in Africa or African countries. Through this process, eSanjeevani has been acknowledged or commended, and we are fortunate to have been awarded the Digital India Award under Innovation in Pandemic category, and was honored by government of conferred by Honorable President of India through the Ministry of Electronics and IT, and various other awards have also been I would say bestowed by various agencies. And I would like to mention that very recently, on the 13th of October, a few days earlier, at G20's ministerial meet in Naples, Italy, Union Minister Shri Piyush Goyal ji, he offered eSanjeevani to the entire world, saying that India will be very happy to share the eSanjeevani platform that they've put together, because no other country has anything comparable to eSanjeevani because of sheer scale and versatility and also user friendliness. So I close with this, and I'll be very happy to address your queries in case you have you would want me to address some. I have a query from Dr. E. Venkataramanna ji. He's asked, will eSanjeevani OPD and eSanjeevani ABHWC be rolled out into private health sector like hospitals and practitioners in future, and whether different vendors would be able to continue using it? Well, as far as the government of India is concerned, considering the popularity and the potential that eSanjeevani has, they've sort of granted us additional funds to put together eSanjeevani 2.0, which will be a state-of-the-art or a next-gen telemedicine platform, which will have all these features wherein both the applications will be rolled into one, and then it will also enable it will increase the efficiency or the productivity in terms of utilizing the doctor for both the variants. As of now, one doctor can practice only on one variant, and in the upcoming version, one doctor will be available, and from whichever side the call comes in, the doctor will be addressing that. Plus, it will also have the provision for the states to rope in private practitioners, and maybe at a later stage, the government opens this platform for smaller clinics or doctors who would want to practice telemedicine using this platform, which might be available for just about everyone. And we have already integrated or made it compliant with National Digital Health Mission's format. That is, we can have the patients can create, the users can create their health IDs, and health IDs, in case they have health IDs, they can log in into eSanjeevani. We are yet to roll it out, but we've done all the testing and it is ready for a rollout. So we are working towards these kind of features, which will increase the reach and access of eSanjeevani further, and make healthcare accessible to just as many people as possible. As of now, eSanjeevani is restricted to these areas which are covered by internet. That is, no more than 40 or 45% of the populace is able to use eSanjeevani OPD, and we are working on modalities which will enable us to use eSanjeevani or make eSanjeevani available even on feature phones and landlines. So those are the efforts those we are making to ensure that eSanjeevani goes beyond the internet coverage, or covers just about 100% of India's population.
Okay, so thank you, Dr. Sodh, for giving a elaborate description of the eSanjeevani. I think many people have known eSanjeevani, they have used it, and it has been properly kind of projected by the Government of India, Minister of Health. So everybody is now thinking of using eSanjeevani wherever there is a project of telemedicine. It's good, a compliment to the SIDAC team, Mohali team.
We owe it to speakers and guides like your good self, sir, and we are thankful to you.
I guess I just want to tell the attendees because the Sanjeevani was not eSanjeevani, Sanjeevani was lost in this campus, SGPJMS Lucknow campus in the 2002.
Yes, sir.
So that's a different story altogether. But we are very proud that ours made in India, that we call Atmanirbhar Bharat, is one of the best examples for that. And we are looking for the day that eSanjeevani will go outside India. Like we're exporting vaccine, we should export also eSanjeevani outside. So, of course, you are already present in some of these collaborative projects of Government of India through Ministry of External Affairs. eSanjeevani's presence is there in a few countries. So I'll just request to take a few questions, because there are a few questions here, because some charts is there. You can see the chart. Questions are coming there. Kindly take up this question. I need not come between you and the attendees. Just
Right.
keep on answering that. Okay.
I have another question from Shri Ravendraji. He's asked, can private person and NGOs also work with eSanjeevani? In fact, in certain states like Jharkhand, Chhattisgarh, and could be Bihar as well, and in Uttar Pradesh as well, few NGOs, I think it is Wish Foundation and then IntelliHealth as well. These NGOs, they've got associated with the state health department or NHM in the state, and they are facilitating the rollout of eSanjeevani, like training the health workers and running some promotional campaigns, and also enabling patients to sort of use eSanjeevani. So that is how NGOs and others are helping the state governments or state health missions to propagate eSanjeevani or to enable eSanjeevani reach as far as possible in the rural areas and isolated communities as well. So I have another question from Dr. E. Venkataji. He's asked if CDAC can help, or CDAC helps other software vendors and developers in complying with EHR and NDHM standards. Although we are not doing it as a mainstream or as an activity here per se, but we can certainly assist or rather guide in case there are any queries. We'll be happy to address any questions. But NDHM also has a discussion forum where, in case you're facing any problems, you can post your queries there, and the entire community present there in the discussion forums or their team, NDHM's team, they help with the implementation, etc. So we too will be happy to guide as far as the time permits us.
Hello.
Hello. Yes, please.
Sir, first of all, congratulations for eSanjeevani. Is like has totally changed the scenario of telemedicine. Sir, I would like to know your personal experience. What are the hurdles you have faced during making this eSanjeevani this successful? Because most of the places it happens that the enthusiastic people like you starts the things, but it doesn't see the light of a day. So what we can learn out of your experience, sir?
I'm sorry. I'm very extremely sorry. Actually, we have crossed the time. So it will require elaborate answer. For that, I request Dr. Sood kindly respond to them. He'll write to Dr. Sood in his email ID. He'll explain to it, because we have got another lectures coming up, another 3 lectures. So unfortunately cannot take, but briefly, if you can, Dr. Sood, you can explain to him. They have 30 seconds.
Sure, sir.
Yeah.
Sir, actually, most of the challenge was this challenge, I think, was really not tough to break for us or to address for us, because Ministry of Health played a very important role in this, or rather they played the real, I would say, catalyst, or they facilitated propagation of eSanjeevani through the National Health Mission setups in the states. So they were responsible, or rather they took up the role of propagating it to just about the entire populace. And that is how, they brought on board the doctors. And then once the doctors were there, I think COVID also helped us to some extent, that since the OPDs were closed, there was no other option. So the patients were willing to see doctors through eSanjeevani OPD. And once they had this experience, I think it is by the word of mouth, the whole experience, or the whole, I would say, platform got propagated faster and further into the population or into the users.
Thank you, Dr. Sood. Actually, we are very sorry not to give you more time because you will again repeat after 3 months. So I'm sure many of the attendees can have a repeat attendance in that, or you can contact Dr. Sood in personally. Okay,
Fine.
also go next presenter is Dr. Professor Sanjay Bihari. He's the head of the department, former head of the department of neurosurgery department here. And he has been active in our telemedicine program, and he played a considerable role in our management of the electronic COVID care system at SGPGI during the peak of the COVID. Still, he has a lot of passion for technology in many other areas also besides telemedicine in his own specialty. So I need not have to spend more time on introducing Professor Sanjay Bihari. His academic acclaims are already put in his brief bio that has been shared with all of you, and it will be appear in the website also after his lecture. So with that little introduction, I request Professor Sanjay Bihari to give his presentation.
So thank you, Dr. Mishra. It's been a real honor and privilege for me to be presenting here. And I'll just share my slides. So this is, of course, a joint venture between Dr. Mishra and when the director asked both of us to actually take this up, and with the infrastructure which has actually taken a lifetime to create by Dr. Mishra, we started two systems, the electronic COVID care system and the electronic OPD system during the COVID times. And of course, the School of Telemedicine and Biomedical Informatics, SGPGI, was the principal, played a very, very important role in actually helping us out. So let me talk about the electronic COVID care system and the electronic OPD activities of SGPGI during the COVID system. So this was the COVID care system, which if you go to the telemedicine second floor, this still exists and the entire infrastructure still exists. So if there is a third wave, we can immediately go and actually start working again. I hope it doesn't happen. So how did the electronic COVID care system service start at SGPGI? So the government during the COVID system, initially we did not have any input. There was no medical input, and nobody knew how COVID would be treated and how we could actually communicate with all the doctors in the periphery. So the government of Uttar Pradesh decided to start the electronic COVID care system services, and our director, Dr. Dhiman and Dr. Mishra, they actually planned the whole thing. So initially, the electronic COVID care system services started with 4 specialists, and they included medical, surgical, intensive care, and other departments. And so preclinical department, this was started on the second floor of the building here, the School of Telecommunication, Telemedicine. And this consisted of 2 shifts of 6 hours duty in which the calls were received from both patients and doctors. And then from 25th of July, we realized that the OPD, we cannot have an open OPD system in which hundreds and thousands of patients are coming to SGPGI, especially in the middle of COVID. So then we started the electronic OPD system, and this merged with the electronic COVID care system from the 25th of July 2020. And this facilitated a direct access to clinical departments. And of course, as soon as that happened, the electronic COVID care system, which was a centralized facility, the number of calls went on dropping because the electronic OPD system of SGPGI took over the management of both COVID care as well as the specialized services which SGPGI was offering to the patients in the periphery. So the main aim of the electronic COVID care supports network was to provide teleconsulting services and remote clinical decision support throughout the state of Uttar Pradesh to doctors, and also to provide teleconsulting services to patients and patients who contacted the electronic COVID care telemedicine network. So it was both in SGPGI, it was both a patient to patient as well as doctor to patient to doctor communication system, which we established here. And what were the categories of patients who actually benefited from the system? One, the patients who had frank COVID infection, who developed severe illness like multi-organ failure or individual organ failure, for example, cardiac, respiratory, kidney diseases, acute neurological, or even patients who were difficult to ventilate, and several other issues. And the important thing here was that during the initial period, nobody knew how to actually treat COVID, and so there was a continuous interaction with the periphery and the center, and this really helped in formulating a policy which subsequently really helped in mitigating the effects of COVID-19 infection in the state of Uttar Pradesh. The second was symptomatic patients who were suspected to be having symptoms of COVID-19 infection, but were not sure of further progression of disease. So at that time, people did not know whether to upscale or downscale the life support, or what the preventive measures were to make sure that medical errors were mitigated. So this was very, very important. And so this continuous interaction on a daily basis really helped in securing proper treatment for our patients and in formulating policies which have still being distributed on a national level and on the state level. Then a very important subset was patients with other non-COVID-19 medical and surgical emergencies who were not able to come to tertiary care hospitals due to travel restrictions in place. And not only were these patients who were not non-COVID patients who required SGPGI medical and surgical care, but even today, the policies that we established at that time are continuing, and several of our patients are still being managed on a telemedicine basis by individual departments. And then there were patients with non-COVID ailments with significant symptoms who were being managed by doctors in peripheral hospitals who did not have sufficient expertise in treating the particular ailment, and therefore either required advice or required these patients to come to HGPGI for management. And finally, doctors and other healthcare workers working at level 1 to 3 hospitals who were managing patients with COVID-19, non-COVID-19 diseases. And whenever they wanted any kind of advice, they could immediately communicate with any department of SGPGI and actually get advice from level 1 to 3 hospitals to SGPGI. So this was a spoke and wheel model. And this was for most of the levels, level 1 to 3 hospitals, this was a doctor-to-doctor link. So from a primary health care provider, so from there to community health center, and then to district hospitals. So this was level 1 hospitals. And then, so they could communicate either with each other or with the tertiary care hospitals. Then there was secondary healthcare providers at 52 medical colleges of Uttar Pradesh. These were level 2 hospitals, and they could actually communicate with all the tertiary care hospitals. And finally, the important link was also private hospitals where both COVID and non-COVID services had started, and they also were regarded as level 2 hospitals. So this reporting was by telemedicine and other telecommunication facilities like telephone, email, fax, WhatsApp, for videos and Zoom conferencing. And this was actually a doctor-to-doctor link, which then communicated with 6 medical institutions where telemedicine facilities were available: King George Medical University, Lucknow, Medical College, Meerut, Medical College, Prayagraj, Medical College, Kanpur, and Banaras Hindu University, Varanasi, and finally SGPGI, Lucknow. So these were regarded as level 3 hospitals. And then finally, we had an augmented electronic COVID care system hub, where both doctor-to-doctor link and patient-to-doctor link was provided by SGPGI, telemedicine center. So this worked very well, and all the centers communicated with each other all through COVID care facility. So at our center, 4 faculty members were electronically present to process the calls and they were from medical specialty, surgical specialty, intensive care specialty, and paraclinical specialties. And there were 2 shifts, one from 8 a.m. to 2:30 p.m. and the second was from 2 p.m. to 8:30 p.m., Monday to Sunday, all days. And all the faculty members of the institute rotated during these shifts. And this was apart from the COVID care health management of patients, which was being done on a rotational basis by all faculty members of SGPGI. So the entire thing required a huge infrastructure, and this was actually facilitated to a large extent by the Telemedicine Center, our School of Telemedicine, because all the facilities were already existing. All we had to do was to connect them to all peripheral hospitals and make sure that there were people to receive the calls as well as to disseminate proper advice to our patients. So there were landlines, there were WhatsApp and Zoom dedicated facilities, email, fax numbers, and this was exhibited also on the SGPGI landline. And of course, the duty roster was created on by a centralized committee of SGPGI, and this was done on a rotational basis. The most important benefit which SGPGI got from it were two. First of all, we did not expose our junior colleagues as well as our nursing personnel to OPD, and yet the patients got benefited because of the healthcare facilities which we could provide through this electronic care, COVID care system, and also through the EOPD system. But there is another very important thing which happened during this time. We suddenly realized the importance of video conferencing facility even during the non-COVID times. And most of the departments are still continuing this facility, and this has really, really helped our patients. So many of our patients don't even have to come for follow-up, and they can, through WhatsApp or through telecommunication landline, they can actually communicate with us, and we realized the importance of this important facility. And at the telemedicine, we could actually, there was a central mic here, and with this electronic system, we could actually communicate, and we had continuous throughout the day, phones kept ringing, and we could then communicate with the individual departments, and the individual departments gave the feedback, and this was again communicated with the patients at different points everywhere. And so you can imagine the district. So we had distribution of district, the Western Uttar Pradesh region we had with Meerut Medical College and with SGPGI Lucknow, Bundelkhand region with Kanpur Medical College and with KGMU Lucknow, the Eastern region with the Allahabad Prayagraj Medical College and Banaras Hindu University, and the Lucknow district region with KGMU Lucknow, and these were the link facilities which were available. And so all consultations took place between two medical doctors at both ends. And telephone and the internet-based telemedicine system were the main backbone for the remote care delivery. Besides audio conference, patient data exchange and video conference were carried out using WhatsApp and other forms of social media tools like Zoom. Photographs of radiology and investigations were conveyed by these telephone and internet-based tools to the patients stationed at referral centers. And a photo transmitting software was also installed to transmit photographs rapidly. And the Telemedicine Center under Professor S.K. Mishra addressed any issues related to the electronic COVID care system network. So what was the nature of calls? What were the type of actions that could be taken for the patients? So we could take calls seeking expert opinion, management of patients, COVID-related management, ventilator care. And in case the query was related to an area beyond the domain of expertise of the people sitting there, then the people were communicating with the liaison officer in each department. And this liaison officer again recommunicated with the patient who had actually made the call and gave the answer to the patient. And in case it was a situation which could not be handled at the periphery, then a situation and circumstances were created in SGPGI to make sure that the patient came here, did a COVID test, and then we could actually manage these patients. And an investigation of radiology was conveyed to the telemedicine center, and this was given to the radiologist, who again communicated back the diagnosis to the patient. And the team of 4 doctors asked the patient to phone up directly, or this team of doctors established a communication with the experts in SGPGI with the situation at the periphery. And of course, referral to an appropriate higher level of medical college was also recommended at certain times. Now, if the patient's immediate health problems required him to come to SGPGI holding area, then an admission was done here, COVID test was done, and then the patient was admitted to the ward, and nearly 100 patients were operated on a monthly basis all through the COVID times. The emergency cases were actually done. And so this was very, very useful for all the patients there. And not only that, every day to the DGME office, we provided data related to the date, session, central registration number, of the patient, then the name of the person making the call, as well as the mobile number. This has been continuously, this record was maintained, the city from which the call was being made, the name of the patient, a brief history of his complaints, and any examination performed by the treating doctor at the periphery, overall impression about the patient's diagnosis. Is it the follow patient or a new patient? What were the investigations which were sent? And this has been now still stored and continuously being used by various departments. The treatment and advice given, the referral steps taken from other departments with the name of the consultant involved, and the steps undertaken to resolve the issue. They were continuously sent to the DGME office, which kept a centralized record from all the hub and spoke hospitals of the state. They were all being maintained. And you can just to give you an idea about the day-wise statistics, you can see that the electronic COVID care system, every day we received so many calls. And then this gradually dropped, because what happened was that once we started the specialized electronic OPD system, where each department could actually take up this activity, then of course we still continued the electronic COVID care system, but then the calls to the electronic COVID care system started dropping, and the individual department calls went on increasing to the extent that a lot of facilities could be done. So this was the monthly facility. Still 300 to 400 calls were actually being managed. And then during the COVID time, from the very, very serious patients, say 14 to 16 patients were being managed and operated. 24 departments then started providing specialized services in the School of Telemedicine. And this were specialized, they were all given special rooms, and they were given computer facilities, they were given all telephone facilities, and then they started delivering their own specialized services to patients. Like you can see here, this is different departments. And then we also had a few computer operators who were actually collecting electronic data on a daily basis, and this was being submitted. And so you can see that month-wise, the ECC has decreased, but the month-wise cases in electronic OPD went on to almost 10,000 cases that we saw. And in all, see, this is only in 3 months we could cater to almost 40,000 patients from all over the state and all over the country. And apart from that, we also started other e-learning activities. So we started tele-education administrative sessions where various departments were frequently connecting with each other and with other hospitals of the country like AIIMS, PGI, and NIMHANS and other hospitals. And we had conducted 129 sessions and 80 medical lectures related to COVID and non-COVID areas were recorded and edited, and some of them are still available online in SGPGI. Then some doctors were also communicating with doctors at the periphery, and this is at the general hospital where generalized services, physician, pediatrician, all of them, an orthopedic surgeon, general surgeon are available. So this was one of the sessions which was being organized. We also started doing a clinical grand round. What we have in SGPGI is that every Saturday morning, we have a teleconferencing session where the entire institute kind of participates, where each department gives either a statistics of the one project, or it gives some mortality, morbidity is being discussed. And so this was also started during the COVID times. For College of Nursing and College of Biotechnology, we started several classes, and nearly 756 classes were being taken. And not only that, for those people who are actually going for COVID duty to the Rajdhani COVID hospital, how to don and doff their special dress, and many other training programs were conducted during this time. Then we have medical video lectures, which are archived, edited, and uploaded at the NMCN portal. And there are multiple subscribers. More than 500 videos are available, and this is linked with PGI, AIMS, and other things. And live streaming is also possible. So multiple lectures are still available, and you can still utilize these facility, which we developed during the COVID times. And then every day evening, from 6 o'clock till 8 o'clock, all the patients who were admitted in the COVID hospitals, the director, Professor Mishra, and Dr. R.K. Singh, who was the coordinator for COVID as the head of emergency medicine departments, and all those people who were actually posted in the COVID areas, they all got together and discussed each and every case who was admitted there, in the ICU, non-ICU cases, all the admissions, and this was actually being organized through this telecommunication systems. And then we also conducted examination through this. So PDCC, MS, and MCH examination was being conducted using telemedicine, and it is still being conducted in parallel. And this is done at the School of Telemedicine. And we have been successfully giving results based on these examinations. And so we have conducted several exams for several hours in a day, which have been conducted there. So to summarize the information regarding telemedicine and e-learning services during COVID-19 at SGPGIMS Lucknow, we conducted tele-education and administrative sessions, which were undertaken by the School of Telemedicine and Biomedical Informatics. And these are using cloud-enabled facility. And then e-learning classes were undertaken for College of Medical Technology by School of Telemedicine, e-learning classes undertaken by School of Nursing. The SGPI Medical Video Library was updated, and this has been uploaded on the NMCM portal and channel, and this can be accessed by everybody. Then technical assistance was given for training of healthcare workers, staff, virtual ICU rounds, and OPD was being done, and Rajdhani COVID Hospital was also being managed. And the patients were benefited through the telecare services of electronic COVID care system and an electronic OPD system of 26 specialty departments of SGPGI, and a lot of emergency patients were managed all through the COVID area using the telemedicine system. And a special thanks to Dr. Mishra for organizing everything in SGPGI. Thank you so much for your kind attention.
Professor Sanjay Bihari, so for your redacted description of what you have been doing here in telemedicine during COVID times and giving a little audit of all the telemedicine activities here. So with that introduction, I may ask all the attendees to ask Dr. Sanjay Bihari anything they want to ask, especially focusing on the telemedicine in the COVID management. They've given you very broad idea, COVID care and how we manage our own OPDs, our own patients, and how we manage our educational activities and how we have managed our exams, exit exams and everything. This is a big experience that you have all gathered. So please ask him all the questions. Many of you must have also experienced this kind of thing in your own hospital. Go ahead, please. There are chart questions coming up. Any questions in the chart, can just have a check. No question till now. But anybody wants to ask questions, they can go ahead and ask questions. But Sheila, you want to ask some question? Yes, I can see the hand. Yes, go ahead. Unmute yourself. Unmute Sheila.
So it's a very nice initiative you've taken, especially for the medical students. You've recorded and put the videos as well as the classes. I wanted to ask you about the examination. What is the examination which you're conducting? You're conducting online exams.
Yes, ma'am.
Is
Yes.
it all short questions?
I'll introduce Dr. Sanjay. Sheila John is the nodal officer of tele-ophthalmology in Shankar Netralaya.
Yeah.
So
so all our MCH examinations are even now being conducted online. And so we have usually 2 external examiners and 1 local examiner from another hospital institute or medical college from Lucknow. We get that, and then we have it's exactly like the same model. We have a long case, short case, and so we give a summary to the to the candidate, and he can also examine the patient. During the COVID times, we were giving a clinical summary to the patient, say this is the long case, this is a short case, and then there was a complete viva on that. But now we are also giving the case to the patient, to the examinee, and he kind of presents it like a long case, short case, and then radiology viva, instrument viva, and even an operative viva is being done this way. And this has been very, very successful because SGPJ has a very unique program in which we first send our theory papers to other examiners. So what we do is we just scan their copies, send it to the examiner, get within a week's time their assessment, and then we have a practical exam. So even the theory as well as the practical exam is being conducted online.
So what is the platform you're using, sir? The platform which you're doing for e-learning, the online.
Dr. Mishra, would you like to answer this one?
No, we use for a real time. We use several softwares we are using. One is Zoom, which is commonly used. Then we have Cisco WebEx. You have the GoToMeeting. Several softwares we use, not one. But everybody finds very comfortable with Zoom. So many times we use Zoom. And for exams also, there are little concern about Zoom. That time you must have noticed a lot of observation by the government and everything not to use Zoom. But because of versatility, we use Zoom. But we had Cisco WebEx also. No issue at all. We do not use, during this time, we never used any standalone video conference system. All use is software-based, never a hardware-based. Just a webcam, we put it here. And that becomes very easy for our remote examiners also to set up their systems there.
Yeah. One question which is, thank you. One question which has come is that does SGPJ have any portal currently for guidance to non-SGPJ doctors? So
yes, it is there. I think Sanjay, you know very well. We have this portal of HTBMS School of Telemedicine, and there we have all the systems mentioned there, different basics of telemedicine. We can write to them to the link if they contact us.
Yeah. So several videos, nearly 500 videos are on that portal, and they relate to very, very common ailments. It's not like only COVID. It relates to a lot of multiple common ailments, and people can just access the site and see the video. They can stream the video and get guidance. The other very important thing is, I think we also need to continue this this communication system wherein we can have doctors talking to doctors for referral. We are having on a very preliminary basis, but after COVID, we actually went back to our regular OPD. So then this kind of didn't work, but several departments are still continuing their follow-up on the basis of the electronic OPD system. There's another question here. Any proportion of COVID-19 patients monitored through ECCS for the entire duration of illness, such as for 14 days? In fact, several patients, in fact, all the patients who were admitted in the Rajdhani COVID hospital were managed using the electronic COVID care, using the telemedicine facility, because the technicians from the telemedicine department went to the director's room, and the special facility was created wherein all the people who were actually involved in COVID healthcare during that time, during that session, were all there, and from 6 to 8 every day we would discuss every single sick patient who was admitted in the Rajdhani COVID hospital. In the electronic COVID care system, we got several calls related to patients who were admitted at the periphery, and all our referral system, say for example, if there's a patient who becomes very sick and requires some care here, this was through the ECCS system. So this was very, very effective in managing our patients.
I think you have been honest, Sanjay, that to admit post-COVID, you have really slowed down in the sense, unless you make it a part of the system, health system of our institution, it will not go on. But you have realized this is important for us, especially for post-COVID problems that you have faced actually. So you have to follow up this question. The question is very right. It's not only 14 days, even beyond 14 days also we should have system of monitoring. It all depends on your hospital functioning, how to do it actually. So I think, Sanjay, that is the time we have actually for you. So we'll go to move next, and
Thank
let
you so
me
much,
tell all attendees also, and to Sanjay also, we'll be having every 3 months this program. So we'll request you again to also come and educate others, right?
Thank you so much.
Thank you.
Thank you so much. Thank you.
So Dr. Sanjay's lecture will be there in the website and as well as the Yahoo channel, YouTube channel. So you can also listen to him again and again. Okay, thanks. So we'll go next to Dilip Raman from Cloud Care Physicians from Bangalore. They are experts in the Tele-ICU, right? And followed by that is Dr. Aditya Kapoor. He's our head of the department of cardiology. He'll come next after this, 30 minutes. So I request Dr. Kapoor to stay in the waiting. And Dr. Dilip, please go ahead. And you know very well this audience. I have introduced to you. I have given you some introduction about that. Dilip has spent a lot of time in the US. He's American board internal medicine. He's basically a doctor like any of us. But he has specialized in the Tele-ICU, and he is helping Indian hospital to set up Tele-ICU programs. So briefly, that is the introduction I want to give Dilip. And of course, your CV will be there in the website, people to go through that in detail. I don't want to waste much time because time is very short. We'll have leave 5 minutes for discussion at the last. Dilip, go ahead, please.
Thank you, Professor, and thanks for making me a part of this. It's much appreciated. I will just share my slide. I hope it's visible to all of you.
Yes, it is. It is visible.
Great.
Go ahead.
We shall proceed. So the thing that we are going to talk about here is something that's very close to what I do every day, which is remote monitoring and tele-ICUs. A brief disclosure on what I do. It's part of my CV. So we'll proceed with full disclosure. Since this was intended as a basic course, Professor had mentioned that we're going to talk about more advanced concepts later. One of the key premises that we should understand is something called the concept of the healthcare iron triangle. And this is what actually enhances the value of tele-ICU and telemedicine services in general, which is that in healthcare, it is very difficult to give high quality with universal access at low cost. So the challenge here is that technology is the one tool that we all look at, which is capable of breaking this iron triangle and allows you to provide health, value, and equitable health to a population at large using the tool wisely. So one of the earlier speakers were talking about different models of tele-ICU and telemedicine in general. And the model that I'm going to focus on is the model that we look at from the RMP to RMP model, which is a doctor supporting another doctor through telemedicine, and that doctor on the spoke site then helps the patient. So since this is a basic lecture, we will initially be talking about these things. However, so much has been talked about telemedicine technologies in general that I think some of this is actually already commonplace. So there are device-based models out there that augment telemedicine, and this has been discussed and will be discussed in multiple directions during the course of these educational series, that I would just want to iterate that people should know about this. We can go into details and how advanced these things can get over time. Going into specifically the tele-ICU part, intensivists have been the most critical piece of outcomes related to critical care, because a closed ICU model that involves an intensivist-led functioning of the ICU has been shown to be associated with improved outcomes over the past few decades. So some of this doesn't need to be revisited, but what is critical and key is that India has a huge shortage in trained intensivists. So by trained intensivists, you would mean somebody who has done an MD in medicine or anesthesia and then go on to do a fellowship in critical care. US has a big shortage, but you can see how massive the shortage is in the Indian space. And the solution typically is technology in the form of a hub and spoke model that has been addressed in multiple fora. But in the US, for example, you're able to take care of 100 to 160 patients as part of a hub and spoke network. Whereas in India, these models are still maturing, and they are maturing mainly because of the bedside availability of technological flexibility, which we can go into detail subsequently. But this telemedicine on steroids, or a supercharged form of telemedicine, which you would call as a tele-ICU or a smart ICU system, is what makes this happen. So this is from our center. The Spoke Hospital is in rural Bihar, where we connect using our technology and are able to take care of this patient. This was pre-COVID, where you can see the patient is not in the caregiver is not in a PPE, but the idea was that this was the first patient that this hospital was able to do prone ventilation on, and that was due to real-time pervasive support of the Tele-ICU system that allowed them to carry on with this level of expertise. So some of the key features of a Tele-ICU system is that you need exquisite high quality videos, because you can get monitor streams, you can get data coming through connected monitors, but what is critically important in a Tele-ICU is you should be able to see the patient, you should be able to look at the tracings, you should be able to look at the personnel, you should be able to look at the tip of the needle and guide the bedside team during key life-saving procedures. So it's extremely important to have high quality video. And this is an example that I'm bringing to you from a very remote part of the country, top 5 most under served districts in India, Motihari district in East Champaran. You can see that even with the current technology on bandwidth that we have, today in India, it's actually possible to give you 1080p video that allows the Tele-ICU team based out of Bangalore to remotely help with the care of the patient. So our nurses, for example, can look at precise even text on the medication so that we can help the bedside team with minute-to-minute changes, how to titrate drips, how to mix medications that are critical, how to look at the settings very, very closely, as you can see here. So a brief layout of the command centers: you have a critical care nurse and an intensivist interacting with the remote doctor. You need to have a dashboard that allows you to do that. And there are various technologies that make this happen. And the reason why I'm stressing on this is we can always do a deep dive on technology, but there is a pretty serious perception about the technology, and this is published evidence in multiple settings, that there is a lot of clinical resistance to it. So rather than focusing on the technology as telecare providers, we should definitely focus on how the operational matrix and how the workflow matrix should be set up so that the care members at a hub location, say at SGPGI, are best tuned to support the spoke hospitals with a proper framework. So it needs organizational change and leadership where the care delivery is planned correctly and the workflows are the most seamless. It's not really the technology that actually is the center focus. Yes, the technology is important. Yes, the technology has to play a role, but it cannot be an impediment. It's an enabler. And on top of that enabler, should you have appropriate workflows and appropriate processes. So there is a lot of research that exists out there, and we have spent considerable amount of time going through. But in the West, what you'll find is there is a mixed outcomes data, both in terms of mortality and in terms of cost. You will have some Western literature that indicates the use case of Tele-ICUs is mixed. Now, the interesting thing is that Indian data is going to be very different from Western data, and we need to generate our own data, and I'll share some of that with you. It is almost impossible to find clean mortality benefit from US data because their foundations are different. The impact that the Tele-ICU will have on US settings are different. But just look at the penetration of technology compared to India and the US. It's just dramatic. Take a moment to take this slide in, because this is where we are starting off. So if you're starting off here, it's actually unfair to use Western data and extrapolate it to Indian outcomes. This was 2 years. This paper was published 2 years after the first Tele-ICU went live in the US in 1998 in the VisiQ group. That's out of Johns Hopkins. And then the lead author here is Dr. Rosenfeld, who was, Brian Rosenfeld was the guy who actually set up the first US Tele-ICU in 1998, which was later bought by Philips in 2008, actually. And interestingly, some of these messages are still being discussed. And I think what we as a group in India need to move forward is that we need to identify keys to success in our setup, explore those keys of success, look at those metrics, and just expand on that, because the use case has already been proven. We don't need to reinvent the wheel in that respect. And that's where we are losing a lot of time. So frugal innovation in our setting is going to be the game changer, where we focus on the functions, we reduce the cost, we definitely reduce the complexity, in the sense that when you're running a Tele-ICU in the West, most people focus on how to connect the device, what sort of jacks to use, what are the frameworks that are needed. We should change that. Just like the US was spending a lot of time in looking at how to use pagers, a pager system in the hospital. India completely leapfrogged that. Nobody in India uses pagers. So similarly, when it comes to tele-ICU, we should not spend too much time, money, or expenses on copying that model. We need to devise our own model. So what you will need is you will need to drop the barrier to look both at the service and the technology, not in isolation. And this is a key message. Too often, healthcare technology companies focus on the technology. One of the key takeaways that we learned while doing this in India is that it's an 80-20 rule. 20% of your effort should be on the technology, and that technology needs to be the best in the world, designed for India. And 80% of the focus should be on workflows, training, and upskilling. That is the only way you'll be able to succeed in the tele-ICU space. And that is what we as a group stress on as well, where you connect, you make a scalable system, you lower the barrier. Then you spend time on digitization and training and workflows. That is your key to success. And in subsequent lectures, as Professor was mentioning, we can go into details of how to do this. What are the nuts and bolts? How do we devise a workflow? That itself is a topic that takes hours to cover, because it is more an operational and a management topic that is related to tele-ICU. Yes, it has connections with technology, but it is operationally dense. So just to give you a glimpse of how complex it is, this is how a day in the tele-ICU or a smart ICU workflow goes. You need technology to assist you to get the data out. You need to do detailed reviews of the patient. You need to streamline on all the documentation so that all of this actually comes to the intensivist and the critical care team. And then you need an empowered collaboration between the two groups. There are a lot of egos. There are a lot of practice changes. There's a lot of equalization of practice that is required. And then you need to be sensitive that in India, some of these things need to be very mobile centric and not workstation centric. So these are very complex things that we are trying to break down, but I just wanted to give you an idea of what a day in the smart ICU in Bangalore looks like when we are deploying this in many of our sites. Then as you go on to the next level, you're going to think about a virtualized care network. And a virtualized critical care network is more complex than a standard telemedicine network, because it's minute to minute. It's supposed to be 24/7, and you need to have access to standardized care and highly trained doctors and nurses to make this a reality. But it allows a leading team, for example, at SGPGI, to scale to multiple areas quickly. And that scale I'll share with you, because there are a lot of lessons in COVID that can actually be applied to what is happening today. So while we were active before COVID, some of the things we learned, in fact, will help large networks get set up very quickly and in a very scalable fashion, because one of the challenges is that we don't have enough intensivists. So if we have anesthesiologists or medicine RMOs or even MBBS doctors who we can support, that intellectual capacity of an ICU team can be disseminated to a much larger framework. It doesn't mean that an ICU can be run without a doctor. That's not the message of a tele-ICU. The tele-ICU is an augmenting tool. It's a complementary tool. You're not replacing doctors. You're just allowing doctors to function more efficiently with a higher level of productivity. That's what we are trying to do. So, for example, in a pandemic, our up and running time was between 5 and 7 days, as long as the government hospital provided us with internet and with power. All the other things we had to quickly deploy. We did not have time to hope for the perfect software or hope for the perfect milieu to make this happen. And that is why we also stress on training. And I was so glad to see the previous speaker also speak about training. And as a tele-ICU provider, we realized that this 80-20 rule that I was talking to you about, the 80% also talks about training, also talks about upskilling. So we partner with a government organization called IHMR, which is based out of Bangalore and Jaipur, to actually run a course like this that allows the upskilling. So before we summarize, I can share some Indian data with some of our government hospitals that we actually worked with during COVID. Here we've plotted the Apache score along with mortality, and we have seen this trend in multiple settings. This is from rural Maharashtra. The previous one was from northern Karnataka. And you see these trends over and over again in many of our government sites. And this is because not that we did any complex stuff and ECMO and you know, for higher forms of ventilation. This was just improving the accessibility to standard ICU bundles. Simple prone ventilation, appropriate oxygen, standard prophylactic bundles like DVT and stress ulcer prophylaxis. These things go a long way when you're stretched for resources in some of these government sites. This is a scale of the deployment, and some of this data is actually submitted for publication in journals. We were able to deploy all of these sites over the space of the pandemic, and we've now seen more than 4,000 critically ill COVID patients. So these are not ward patients. This is a database of 4,000 ICU patients that we took care of, and in these diverse settings from Leh to rural parts of Maharashtra and Karnataka. Like I was sharing with you, you need Indian data to understand what the Indian context is. So some of this is the only tele-ICU related eCPR data or tele-CPR data, where a remote intensivist ensures that the bedside is able to follow ACLS and BLS principles according to standard published AHA guidelines. This was a tele-CPR pilot study that we published with just 25 patients. Now we have a data set of about 700 CPRs that our tele-ICU team has monitored, and that also is being prepared for publication. Not just from the core critical care space. If you have a network that has all the data on one platform, you can even look at antibiotic prescription practices. You can look at antibiotic stewardship concepts that can be plugged into your tele-ICU framework. So for an academic institution and for critical care academicians, data collated on a tele-ICU platform is very, very valuable from a practice change perspective. So we looked at antibiotic use in our surgical ICUs to enhance how we can actually improve their compliance with standard bundles. Interestingly, looking at remote monitoring, it is a key area where you can actually make sure that the patients who can improve and can heal at home should be given an opportunity to do that, because that is where their recovery can be very, very smooth compared to the delirium and risk of infection that they may be subjected to in a standard ICU. So that is also some work that we have done, and you know, trainees can actually take this as a opportunity for research and training going down the line. So some of the future directions.
I have to interrupt you. I have to interrupt you, Dilip, because the time has come. So
Sure.
there's some questions we have to take up actually. So allow some time for the attendees. So your slides are always be loaded in the YouTube. So the remaining slides also can be seen by the attendees. Okay. And my request attendees, kindly ask your questions through either way through chat, or you want to ask question, better to put on chat. You can manage easily.
Yeah, please go ahead. Happy to take questions.
Okay.
So one of the questions was, doctors posted in remote areas need super specialty opinions. This is exactly in line with what a tele-ICU can do, because once you plug it into a tele-ICU framework, you can get neurology, nephrology, cardiology, all the specialties that you are looking at can be plugged into this pervasive model of getting subspecialty care. The other question is second to monitoring, getting critical information, quick decision support, how to overcome the high expertise and skill gaps. So that's exactly what I was talking about. We have to stress on teaching, upskilling, and training as part of the tele-ICU model. It cannot be in isolation. And this is what we also do in our network. We do upskilling and training. We have our nurses and doctors going remotely to help with that. And at the same time, we have to focus on the interpersonal aspect so that the people who are getting upskilled can actually use the framework to, in fact, take up that and improve in their skills so that they can best utilize what is available to them.
Okay. So any other questions? Please put on the chart. Okay. I think we should think about training part. That is, you have highlighted that you have already associated with some institutions for training. But what is more important is while you deploy a project, so you must have encountered one part of the training which is very important for us. that you train a group of people, then in government systems, they kept transferred. The nurses get transferred to another ward. They, like in the ICU nurses, they can go to the surgical ICU, they can go to any other neonatal ICU, or they can go to operation theaters. So how to face this challenge that you train a group of people and they're kind of going somewhere? So how to train them? New batch. So don't you think you face some problem like that?
Yeah, you have to keep doing it, Professor. I think, the nursing transition and doctor transition needs to be factored in while your training program is live. So just like you are planning to repeat the training program in 3 months, we have a similar policy where we repeat the training program for new nurses and doctors in these sites so that they are continuously upskilled. That's very vital.
One question has come from Mr. Archit Pandhari. How well Tele-ICU costs?
Yeah, the Tele-ICU cuts cost in two major ways. One is in remote areas. One of the only things that patients have is they need to move to a bigger city. And immediately their per day costs in smaller ICUs is transition to a corporate ICU cost, which is very expensive for them. And as domain experts, any intensivist will tell you that as long as we have access, many of these conditions that do not require advanced interventions and only require supportive critical care can be managed in small to medium-sized ICUs. Thereby, a patient who is in Muzaffarpur or in Motihari does not need to drive to Patna, where their per day ICU bill will go up by 2 to 3 times. So this is one way where it definitely cuts costs for many of the patients that we have helped, and they're able to manage and stay with their own family locally. The second way it cuts costs is that some of these high intensity interventions can actually be carried on earlier, in the sense that everybody in an ICU would know that the golden hour or golden 6 hours is critical for appropriate treatment. If you do things at the right time in the initial part of their illness, when they present to the tier 2, tier 3 hospital, in fact, actually cuts costs for them because effective therapy has already been instituted at the right time.
Dilip, I want to introduce you Dr. B.K. Behra. So he is the Chief Medical Officer of NTPC. NTPC also has deployed Tele-ICU. I do not know which agency is handling that. So, for them also, for a PSU, so they used to really spend a lot of money in sending their patients to different locations. But now they are being managed by their own kind of projects of Tele-ICU and connected to some leading hospitals. They have been supported there. So this is very important that many of the PSUs are also taking up for Tele-ICU thing. But if you can do a good cost analysis and put it to the government, I'm sure the government will expand this network.
Absolutely.
Like currently the government of UP is setting up a Tele-ICU project for only 6 medical colleges. I'm sure the government of UP is setting up 50 odd medical colleges or 70 odd. Every district will have medical college. We need to have such kind of network in place. Next question is Sudha. Training by AR, VR, MR technology will definitely give a better support in telemedicine. I mean, what I mean to Tele-ICU, telemedicine altogether. So Dilip, you can take up as the last question.
Yes, this is true. And interestingly, we are looking at AR tools, not VR tools. We are looking at AR tools because that really helps in teaching the nurses and doctors at the bedside about, say, using a ventilator device. So we combine the bedside tool with the augmented reality experience. And we've actually done an internal pilot on this. I completely agree. These are the tools that are of the future and need to be enhanced and encouraged.
That's great, Dilip. Nice listening from you. And most of the ICUs are handled by the anesthetist, but you are an internal medicine person and very nicely explained. And we appreciate your research acumen also. So we'll keep on requesting you to participate in our this 0102 course in HGPGI and also be present whenever we request you to participate.
Absolutely.
Thanks again for committing this time.
Thank you.
Okay, so we'll go to the next presenter. Last presenter of today's session is Professor Aditya Kapoor. So he is our head of the Department of Cardiology. Also, you'll listen to from him some of the Tele-ICU part also, because that is very important, acute cardiac care, etc. I'm sure we must be having all those slides to share with you. So Professor Kapoor, please go ahead.
Good evening, sir. Thank you. Are my slides visible?
Yes, yes. No, it's not visible yet.
It's visible, but not slide. That is not open.
Not opened actually.
I'll go again then.
So your screen is visible, but your slide is not open.
And now it's coming over. That's great. Make it full screen, please.
Yeah,
That's great.
So thank you, sir, for giving me this opportunity. And Dr. Dilip, fantastic lecture. Learned a lot. So Telecardiology is now amongst the fastest growing branches. We are acquiring patient data related to various parameters. I'll describe them. Transmission of patient data to a healthcare setup and delivery of tailored feedback, which is tailored according to the patient need, whether it's a new investigation, drug titration, or even advising hospitalization. And the history of actually telecardiology dates back nearly 100 years when the first ECG was developed. And this guy, William Einthoven, he actually transmitted the ECG through telephone wires to a hospital 1 kilometer away. So that's an interesting perspective. So we'll briefly cover 5 things permitting time. Tele-ECG, of course, this is all historical thing now because most of the ECG is now being transmitted by WhatsApp. And the beauty of this is that if you see, this is actually a GVK Emory ambulance in South as part of the Tamil Nadu Chennai acute MI project. Acute MI ongoing in the ambulance, the paramedic transmits the ECG to the doctor in the ED. The doctor advises thrombolysis. The guy is thrombolized in the ambulance and significant ST resolution. The patient is transferred to the cath lab and the artery is opened. So all sorts of ECGs can be transferred to the patient, including arrhythmia diagnosis can be made. So that is usually being done by WhatsApp now. Teleauscultation, Dr. Dilip mentioned briefly. So we all know that many murmurs in children, they are actually innocent murmurs. They lead to significant parental distress. Referrals from rural areas, where there is long travel times, huge overload on the healthcare system. So these are, digital stethoscopes. The Viscope is one of them, wherein the sounds can be transmitted to the cardiologist at the main server. And there has been a lot of data. This was, the asynchronous transfer. This is data from UK, and found that functional and organic murmurs can be beautifully distinguished. So unnecessary referrals can be avoided, and even store and forward teleauscultation is possible. This is again data from the Royal Brompton and the Canadian groups. Various sorts of murmurs: ventricular septal defect, aortic stenosis, aortic regurgitation, even tetralogy of fallow congenital heart disease. There was good amount of differentiation between innocent and pathological murmurs. Remote diagnosis of congenital heart disease is possible, so that whatever patients are required are referred, and innocent murmurs, the people are not forced to come long distances to the hospital. And nowadays, this is Littman scope to scope. That is, audio gathered on one Littman model can be transferred to another anywhere in the world. And this is actually being utilized by the Japanese space agencies to listen to the heartbeats of astronauts in real time by transmitting their heartbeats in audio format to the doctors on the earth. Tele-echocardiography. So this is again parallels drawn from the aviation industry. This was part of the TESSA project and the ARTIST project, wherein experts on the earth actually used an ultrasound scanner on the spacecraft, and the images were beamed back. The ultrasound scan was either performed by an on-site person, the fellow astronaut, or robotically. And this is actually being done. This is a project which was started in 2007, and really nice images could be transmitted. So this was the genesis of tele-echocardiography per se. And this is robotic tele-ultrasound. Either the robot is managed by a technician, or even a remote robot just does the scan and transmits it to the server. And this has huge amount of applications in India, because as Dr. Raman also said, there's a dearth of specialized pediatric cardiologists or good echocardiographers. And nearest good machines or experienced guys who can do an echo are really far away. So transmitting real-time images between peripheral hospitals and tertiary care centers is now feasible. And this is what is being done in India. This is a tele-rad technician, technology available in Bangalore, the CardiaSpa machine, and it is linked to the hospital CardioPack system. So good data transfer between the peripheral hospital and the tertiary care hospital is possible. A specific thing for cardiology: remote patient management for heart failure. So this, just like Dr. Raman mentioned, for ICU patients, nowadays we know that a lot of people who are getting heart failure, they get re-hospitalized. Nearly 50% get re-hospitalized within 3 to 6 months, because the follow-up of these patients is often suboptimal even in the Western conditions. There is low adherence to drugs, failure to recognize early signs of cardiac decompensation, poor referral system. The guys often wait in line at the GP level or at the clinic level before they are actually referred to the tertiary care hospital. They may decompensate. So telemonitoring or remote monitoring of these patients of chronic heart failure so that therapeutic measures can be instituted in time. This is very, very integral part of telecardiology now. Only monitoring body weight, which was done previously, is fraught with errors. So we can do a multi-parametric monitoring of all these parameters and a two-way communication between the patient and healthcare providers in terms of video conferencing with good data transmission ability, so that it can be managed by the doctor using a remote facility. So either you can use phone-based systems or implantable hemodynamic monitors, which I'll briefly touch upon. Really fascinating technology in cardiology. So phone-based system actually used to monitor the vital signs of the patient. The patient used to record these and transmit the data on the mobile phone, and the doctor used to take stock of the situation and either issue alert notification for admission or advise about treatment modification. And these are data from West nearly 10 years ago, the dial trial, wherein the nurses actually paid attention to all these things, the daily weight, daily physical activity, symptoms, and found that nurse adjusted diuretic dose just by telephone really led to reduction in events. And this was followed by the Trans-European Registry of Hospital of Home Monitoring System only for sick patients, so that the patient records this data here, transmits by a data server either to the nurse who gives advice directly or gives advice through the doctor. And it was found that again, significant reduction of events at 1 year. The second component of telecardiology in terms of remote monitoring is implanting hemodynamic monitors, because these monitors go beyond what the phone-based monitoring is doing. It records actually pulmonary pressures, filling pressures, and even the chest wall impedance, which is a surrogate marker of accumulation of fluid in the patient's body. So this is the one which is FDA approved. A small device is implanted in the pulmonary artery, and it measures the pulmonary artery pressure. So if you see over here, the pressures at admission or at implant were high, but with actually carefully adjusted diuretic doses, the pressure slowly settled down. So the doctor can monitor the pulmonary artery pressure remotely. Other devices apart from the pulmonary artery monitors can be implanted just like a pacemaker in the right ventricle apex. So this is a sensor lead which is implanted in the RV apex, just like a pacemaker if you see over here. And this is how it looks like on the X-ray, and it monitors various parameters, and the data are directed through the cloud-based system to the doctor who can advise therapy. So this is a beautiful trace showing a rise in the pressures. And when the doctor rings up or the nurse rings up the patient, the initially patient says that everything is fine. But when the pressures continue to rise, the patient actually says that the weight has increased, he has been non-compliant. So the diuretic dose and the beta blocker dose is adjusted remotely, and the pressure slowly settle down. So this is the beauty of all these devices. Not only in the RV, we can implant certain devices even in the atrium, left atrium. So this is a left atrial pressure monitoring device called the heart pod. And this is a patient advisory module, which is like a personalized digital assistant to the patient. So it alerts the patient when to take the data, how to transmit it, and actually gives the instruction which are monitored by the doctor. So when the left atrial pressures are low, it says hold the diuretic dose. If the pressures rise, the doctor can advise a change in therapy, and slowly the pressures will settle down. And this is how these devices look like. They're implanted through the venous system and put in the left atrium. And if you see over here, initially the pressures are high, but with tailored therapy, the pressures can settle down. And now even with more miniaturization of technology, they are doing away with the monitor. So it's just a small umbrella shaped device. This is a miniature wireless battery free device, which can be actually, this is how small it is. It can be actually left inside. It's a wireless thing. And the patient just puts on a light belt, which is a Velcro based thing. So if you see over here, just a light belt which wirelessly syncs the device, and the data is transmitted to the medical professional who can again analyze the reading. So this is all technology in process. It is not yet FDA approved, but I'm sure in the years to come, it will see the light of the day. And lastly, what we can do is we can actually measure the impedance or the resistance of the thoracic wall, so that the fluid which is accumulating in the patient can be measured or titrated. So these are actually inbuilt in the pacemakers or the devices which we are implanting. So it can monitor the chest wall impedance, and once the impedance falls, we can understand that the fluid is accumulating and changes in therapy can be advised. Even more sophisticated system, these are wearable system, edema guard monitor, which only targets lung impedance. It does not include the chest wall impedance, which is more specific than the previous impedance monitors. So this is the most important trigger for drug adjustment. The patient just wears the device, and as you see, the trend of the impedance tells when the lung water is increasing and when the diuretic dose is to be adjusted. So lastly, remote monitoring in patients with implantable devices. As we are seeing increased number of these patients with all these implantable devices, many a time we advise them 6 monthly to 1 year follow-up just for a battery, checkup. Most of these visits are, in the sense, not really clinically warranted, because the patient just comes and waits in line, and it's a 15-minute job which can be done by a remote monitoring. So most of these visits are clinically irrelevant, not only for the patient, but it's a burden on the healthcare system. So long distances, waiting times, time off work, use of hospital resources. So data can now be wirelessly transmitted from these devices. The doctors can, analyze the battery status, can analyze the arrhythmias, as I mentioned, can analyze the fluid accumulation. So patient does not need to come every 6 months. He only comes in when there is an emergency. So this is how the device is in the patient's body. The data is transmitted wirelessly to the doctor. And if there is a change in the parameter, then only the patient is called to the hospital. And the last thing which I wanted to touch upon briefly, these are now radar systems, contactless systems. They avoid an invasive procedure. They can transmit a large amount of data wirelessly, so that whenever there is they actually put in there is a radio receiver, and the chest wall displacement which happens can capture the respiratory and the heart signals and filter out the environmental noises to get a clean signal. So these are miniature sensors. So this is how they detect the cardiac rhythm. The data is harvested from small sensors which are strapped to the chest with Velcro, and tiny accelerometers actually measure the rotational motion of the chest and can extract data related to the ECG and can generate beautiful ECGs. And now the technology is going beyond that. The patient does not even wear anything, and just wirelessly the ECG can be sort of algorithmically captured. So the message for telecardiology per se: faster diagnosis times, especially in terms of acute MI, faster therapy times, the patients can be reperfused early, often in the ambulance, rapid arrhythmia detection, especially for patients who have had device implants, monitoring of sick patients like heart failure, and reduced healthcare burden of routine hospital visits. So as our patient population ages, rising trends of comorbidities, widespread availability of newer drugs and devices which warrant close monitoring of the patient. And we all know, Dr. Raman also said, there is a dearth of qualified healthcare professionals and medical resources. So we have to figure a way around that. And telecardiology, especially in the times of COVID pandemic, has become an indispensable measure. We actually wrote a position paper on this in Indian Heart Journal, because telecardiology is now, especially in the times of COVID, all set to grow exponentially in the times to come. So messages, conclusion: the patient should always be initiated into home follow-up of these monitoring systems early after hospital discharge, so that the patient becomes familiar with the device, especially elderly patients. We as doctors and our paramedical staff should also be educated about the operational technicalities of these devices. These devices or these monitoring systems may be costly, but they will cut down on many hospital routine visits. And that is why, keeping the cost in mind, one should not do a remote monitoring for all patients. We can identify specific subgroups, that is patients who are sicker, patients who have multiple comorbidities, who do not have healthcare givers at home, who have devices, so that maximal benefit can be achieved for these telemonitoring systems. Thank you for your attention. Thank you.
I think it is a back-to-back, very interesting thing. Both are kind of 24/7 monitoring situations. And I think Dilip must be there still attending. So I think Dr. Kapoor, you must have realized that how fast this particular remote patient monitoring concept has really taken up. So from remote monitoring patient is now applicable to many specialties, not only people previously used to think that the cardiac failure patients on pacemaker, they should be remotely monitored. Now it has become, there are many companies in the Western countries. Dilip is there also in US, you must have known about these things. They have business of, in the US, everything is insurance based and everything is company based. So there are like Mayo, like all this Kesar Permanent, they have established divisions for telecardiac services. In the sense, not one services, there are many. So Medtronic, etc., they have introduced many years ago. You are all familiar with that, for their own benefit, for their own devices, how they monitor. And a lot of tele-interventions are also done. Tele-interventions. So that also part you need to also introduce in the next presentation of yours when you invite you after 3 months. Like the teleangioplasties. So all these things have been demonstrated in India itself. So that is also part of the telecardiac interventions. And the one thing that I want to ask today, this also, the new presentation, do it after 3 months, kindly consider about that. A lot of ethical issues and as well as security issues. Security is more important. So in ethical issues, I don't mind the technician gives your injections for anticoagulations. That is a life-saving position. Nobody is going to raise any questions. But when you are making a network of your patients with the devices being controlled by a third party, and the devices are such, if they can remotely mismanage, that can lead to the death of the patient, like especially the pacemakers. So how frequently you are getting such kind of observations in your literature where some of this kind of are happening in the world? This is a very important thing. We need to, because there is a question also coming from Dr. Behra and the previous presentation, Dr. Dilip, saying that is Tele-ICU services are gazetted, in the sense, is it legalized, right? He asked that question, even notice that. So it is legalized. So I did not really discuss, as a big area. We are going to discuss that in the telemedicine context next month. So can you just highlight on those points, like tele-intervention, first point. Second point is, what do you think the security implications of this kind of system in the hospital, where you have a complete monitoring of the systems by a third party?
Sir, I'm really glad you asked this question, because I did not touch upon it, because incidentally, we wrote a paper on this, cyber attacks and cardiac implantable devices. Is it feasible? Is it a risk? Because you are absolutely right. This was a security issue raised, and I am forgetting the name of the US movie. This was about 10 years ago. This showed that the vice president of US, he is implanted with the ICD, and he is kidnapped by somebody, and they actually hack into the device and trigger a R-on-T phenomena, and they actually assassinate him remotely. So that is one part of this. But the reality is that theoretically it is possible, but all these companies, all these St. Jude's, Medtronic, which have these devices, they have their cyber softwares which are very, very robust. And every year their cyber softwares are reviewed by FDA. So remote hacking is absolutely impossible as of now in most of the devices. What can happen sometimes is that if the patient has a remote monitoring system and a malware gets into his home system, then sometimes there have been case reports of inappropriate sensing and inappropriate shocks happening. So this happened with one of the St. Jude's, it's called the Merlink software. So they upgraded the software. So theoretically it is possible, but I think in the next meeting I can cover briefly on that, because there has been a lot of concern, and the Heart Rhythm Society of USA recently issued a position statement that cyber attacks or cyber corruption of these devices as of now is not possible with all these standard companies. So it's a great question, and I think it was so relevant, and I'm glad you asked it.
The second part is the tele-intervention. So what do you think that we saw in that Akshardham temple, that demonstration, it became a news, viral news for everybody in social media. So after that, any other system is running where the people are doing tele-interventions?
Sir, there is this robotic PCI, robotic angioplasty arm. So what they have been doing is performing angioplasty about 40-50 kilometers away. But I think for the Indian thing, it is so prohibitively expensive that doing a robotic PCI is probably not acceptable as of now in the Indian context. What I would say is that maybe Dr. Raman would also like to contribute to this. Sometimes what happens is that with WhatsApp now being there, we get so many of our students who upload the angio, when they are stuck in the cath lab, they post the angiographic videos, that what should be the next step, and more often than not they get a live feedback on the WhatsApp. So I think that is the best part of telecardiology which is happening now. So maybe Dr. Raman would like to.
So I would like to take the benefit of Dilip is here. So I'd like to add something to this that you have been discussing. Dilip, go ahead.
Yeah, great points, doctors. Actually, in the ICU space, there was a question regarding intubation, and that was asked. So we have done this live guidance where the bedside provider did not know how to intubate. So we had to use and teach them how to use the LMA within a span of 10 minutes and actually save the patient's life, because they could use the eye gel because the learning curve is very short. So if they had an experienced, calm person guiding them, telling them, take a deep breath, don't worry, do this in an orderly fashion, that doctor was able to intubate and save the patient's life. Well, in that case. But that said, what is on the horizon is that there are robotic intubation devices that are out there. It's like a helmet-like contraption that can go over the patient's head. All they need to do is sedate the patient, and using carbon dioxide and respiratory tracking. This has been piloted by an Israeli group, which is frankly very exciting work in the space of life-saving intubation. I mean, you can imagine how game-changing that could potentially be. So these tele-interventions are round the corner. As the technology matures, they will be coming through and helping care providers and doctors and nurses at the bedside give better care to the patients. Regarding the Tele-ICU, in the Gazette notification, it is there as a passing mention. But there are some intricacies around it, meaning controlled substances are prohibited. Therefore, we and many other Tele-ICU platforms adopt the RMP to RMP model, where the RMP at bedside is administering the scheduled drugs and not the critical care provider. So I think, again, this space will mature over time and get much better as the legal framework catches up. And we look forward to pioneers in the entire space actually pushing this forward, because like everything else, the legal framework will lag behind innovation. That happened with driverless cars. The ethical questions were answered by driverless cars before the legal framework caught up. So that's going to happen in this space as well.
So I request all the attendees, please ask your questions in the chat, or anything you want to contribute also to this discussion, please put in the chat. Even if you comment also, it is welcome. We have a couple of minutes more, so we can really extend our discussion. I have also a few more points also to discuss, but let me just give attendees the chance. Okay, while the attendees are framing their questions or thinking about the questions, I'll have 1 or 2 points for you people to just look at the future. With the future of medicine is here. You know that we are going to settle in the space, right? All of you know that. So that you're going to settle there for 15 days or 2 months or 6 months, already people are staying there 6 months, right? So in fact, the telemedicine started with telemetry. That is, for astronauts, you monitor their vital signs. Now the ISS is there, the space station is already there, people are staying there. In fact, the gentleman from France who did the first experiment on robotic ultrasound, he came here to Lucknow. One of the conferences, he was also participant here. So he was doing a project called Project Mars. So thinking that when the people go settle in Mars, how their ultrasounds, echo, etc. can be managed. So I know him, I was following his work, and it was ultimately introduced to the market. So I'm not going to that particular high-end gadgetry. I'm just asking to both of you, both Aditya as well as Dilip, don't you think that you can tell our attendees, there are very small things to do practice, we can do it actually. And today COVID has taught you and taught all of us that many things you can do it, right? Out of desperation, all right? And let me use that, use desperation. The same thing which before COVID you used to think risky, but during COVID, you took that risk. I'm giving small examples, like, the anticoagulant adjustment after the valve surgery. One of these, diabetes, many other conditions, like you have arterial thrombus, you also give the many conditions you get arterial thrombus. So I'm basically 2 or 3 points. One is how to adjust the dosage, how to ensure compliance of the medicine, especially Aditya, you know very well, chronic heart failure patients require a lot of these things. Some of these devices are available now by default. You don't have to go. Amazon gives all those virtual gadgets of your monitoring of the biomedical signals. So can you make this telecardiology as a consumer product? At least for people who are staying very remotely, they're inaccessible, very elderly people, children are not there with them. People are talking about medical homes. People are talking about home as a healthcare hub. All this has come up in last COVID times. It was there before, but during COVID time, it has come to every country. It is there in the developed countries. But now in India also, people have developed a Tele-ICU. I'm sure Dilip also must have some example during COVID times. You must have been getting some offers to set up an ICU for a rich person at home. So I just request both of you, or Aditya, you can start, and Dilip can also give comment on the Tele-ICU in these things. Or Aditya can tell me what are the conditions that you can think of that you can start in your department. Now you're head of department, you can start a telecardiology program with some simple things, as I told you, anticoagulation, etc., drug compliance, chronic cardiac patient monitoring, and you are planning for cardiac transplantation. Naturally, you like to have the patients to be monitored. So please come out what you can do.
I think that's a great suggestion. So taking cue from this, what we had already done, as you rightly said, desperate times make you think of some solutions. So in the COVID times, what we had started doing for our arrhythmia patients, because sometimes the arrhythmia patients, they have episodic arrhythmias, they don't have such periodic arrhythmias that they warrant continuous monitoring. So nowadays we have this there's a not like a Holter, but it's a 14-day device. So it is just a strappable electrode. Maybe Dr. Raman would also know about this. So it's a strappable electrode. It's just you strap it to the patient, he goes home, and for 14 days you get the entire ECG information through cloud, on your email. So you can actually access the rhythm records for these 14 days for these patients. So Holter has a problem that it gives you 24-hour snapshot. So this we have been using very frequently, and I really like the idea which you talked about the INR monitoring, because these patients, again, the PT INR monitoring is very critical. And nowadays, I don't know whether it's available in India, but there's a device called the ThromboCheck. So it actually, for prosthetic valve patients, it can monitor the intensity of the prosthetic valve clicks. So once the clicks sound goes down, the patient is alert that there may be some problem in the valve or panas or something. So we can think along these lines for PT INR monitoring, but for arrhythmias, we are already on the job. That's a great suggestion, sir.
Very good. Dilip, want to add something else? Otherwise, we'll close the meeting.
Yeah, Professor, just one comment there is that we should use these things as soon as possible in our practice, because some of them are very easy. The additional point that I had was the safety aspect, because we just talked about hacking and penetration into secure networks. See, one of the key things is, especially the younger providers who are coming on board need to be very knowledgeable about the security framework. So WhatsApp, for example, it's owned by Facebook. All the data is currently not legalized or mandated to be on Indian servers. So I think we should just be cognizant of that. Sure, in a pandemic, we were all stressed and we were pushed to the wall, so we had to use it. But as the legal framework catches up, maybe WhatsApp should be pushed from a regulatory body to host all its data within Indian borders. Data localization is a complex subject that hopefully we'll address in other parts of this educational session. But that is important, because if we are going to do these easy ways to help us every day, we should just have these guardrails in place about consent, about where the data is going, and just be cognizant about that. So that is something that I just wanted to mention, because technology is easy. We'll find it everywhere.
Okay, great. So we have one question. Dr. Venkatesh and Bikabera, they are given comments. I'll go to the questions that how accurate are the measurements of the SpO2 heart rate monitoring by smart watches. These measurements can be used in clinical practice. Can it be?
Sir, regarding these smart watches, the Fitbits and all, the data about heart rate is pretty okay, because there have been recent studies. In fact, there is a huge study now, the Apple Watch study, which used the Apple study to detect paroxysmal atrial fibrillation. So this was a huge study just published in NEJM a few months ago. So heart rate monitoring by these devices, if the devices are good and they are standard make, so they are pretty good.
Good. So that's the last comment, and we'll close this session. And a lot of insights has come. We'll include all those things in the next presentation of yours, Aditya. So thank you very much all again. And tomorrow again we'll meet to listen to another 4 expert lecturers. Thanks, sir.
Thank you.